Good morning and good afternoon, everyone, whichever coast or time zone you may be joining us from. I'm Grace Rubenstein with Health Begins, and thank you so much for being with us here on our webinar about preparing clinic leaders and staff for success on the journey upstream. We want to let you know just before you begin that this webinar is going to be recorded, and we'll send a link to the recording out to all of the registrants after the webinar. All of your participant lines will be on mute throughout the presentation, but we really want to hear your questions. We'll be reserving time at the end of the presentation. It's an hour-long webinar for those questions. The way you can send them to us is to use the question pane that's on the right-hand side of your screen. We'll be checking those questions throughout the presentation. And as we get ready for the presentation to begin, we'll just do a quick look here at the learning objectives for today. By the end of this webinar, we want to be sure that all of you have solid answers to the following questions. First of all, how can we effectively engage clinic leaders and staff to implement workflows and tools addressing the upstream health-related social needs? Then, who are those champions at the clinical sites? How can we best support those champions? And what are the best ways to use and share data to prepare those sites for success? A few extra notes just before we begin. A reminder again that your questions come through the Q&A pane on the right-hand side of your screen. We'll get to those near the end of the hour. And please feel free to send out any highlights, questions, or quotes that really resonate with you while we're going through the presentation today. There are Twitter handles right there at HealthBegins and at Healthify US. I'm going to get ready to hand it over to our wonderful presenters today. We have Rishi Manchanda, President and Founder of HealthBegins, and Monik Bhatt, CEO of Healthify, and we are going to start it off with Rishi.
Grace, thank you so much, and welcome everybody to today's webinar. I'm really pleased to be on the webinar today with Monik, and we'll hear from him in a moment. First, a quick snapshot about HealthBegins for those who aren't aware of us. We're a mission-driven consulting firm, and we really focus on improving care and the social determinants of health, and specifically by focusing in on making clinical and community partnerships more effective and more efficient. Monik, I'll turn the baton to you so you can do an intro for Healthify.
Excellent. Thanks, Rishi, and thanks, Grace, for introducing us and setting the stage. And thank you for everyone joining. As Rishi mentioned, name's Monik. I'm the CEO and co-founder at Healthify. Came from a background of doing community health work in East Baltimore, and really felt firsthand the struggle of addressing social needs at scale for families in need. And that's really all we do at Healthify. We help underserved communities by really building the infrastructure to integrate social determinants into healthcare. And that's everything from providing the platforms and tools and technology to help folks screen for needs, connect to services, and coordinate referrals to close the loop, to actually helping folks think about the workflow and building the networks to coordinate care in their community. We've been at it for almost 5 years, celebrating our 5-year anniversary actually next week. And I've been really blessed to support communities nationally with a variety of health plans and health systems. And I'm quite excited about the topic at hand today, because I think right now in the social determinant space, and Rishi, feel free to add to this, a lot of people are talking about the relationships with community partners, which is absolutely crucial. But another large component that a lot of people struggle with, we found, and we've struggled with here internally at Healthify, is how do you get clinical sites bought in too? And that's really part of the puzzle as well that we'll hopefully provide more color on today. Rishi, back to you.
Monik, thanks so much. And so let's get engaged with everybody on this line right now and do so through a poll. A poll will now launch, and the poll questions are as follows. Does your organization have a clinic engagement strategy to support the implementation of workflows and tools that address health-related social needs? Again, the emphasis here is, do you have a clinic engagement strategy? The answer choices are there in front of you. To my knowledge, we don't have one. We are developing one. We have a formal clinic engagement strategy in place to help a handful of sites, or we're updating our strategy so we can scale and support many more clinical sites to address health-related social needs. Let's keep the poll open for about 10 more seconds. Invite all of you to submit your answers. And let's go ahead and close the poll and see what people said. It looks like nearly more than 4 in 10 don't, at this point, to your knowledge at least, have a formal clinic engagement strategy. A good number are actually close behind, about 4 in 10 are developing a more formal clinic engagement strategy. So we're really excited that both those two categories are on the line today. I think we'll try to tailor our comments to this majority audience. The great news, though, is that a chunk of you, a significant minority, have a formal strategy already in place for a handful of clinics, and then a small number are looking at ways to update that strategy to scale. So really great kind of temperature check on who's here on the line together today. And again, Monica and I will do our best to try to speak to each of these audiences, each of your experiences as well. So to do so, we wanted to provide a little bit of a framing for today's conversation between Monica and myself, and then engage each of you to use this kind of frame as you're thinking about your own practices and your own needs. For HealthBegins, we have an upstream clinic engagement strategy that really is a synthesis of 4 basic steps, and we're going to unpack these in the course of today. The steps, as you can see from the top, moving clockwise, start with discover, and that means both analyzing your stakeholders, specifically clinic stakeholders, as well as doing a cultural assessment. For today's purpose, we're not going to do a deep dive on the cultural assessment component, but we will speak a lot more about the stakeholder analysis and engagement. The next step, moving to the right, is moving from analysis to actually putting together a concrete stakeholder engagement plan for clinics, and then moving to actually implement that plan to engage your clinic leaders and staff. And then finally, how do you make sure that there's a continuous process to respond? So this is a basic frame. Obviously, the question now is, how can we understand each of these components in depth? And with that, we wanted to do a deep dive starting with topic 1 for today. How can we effectively engage clinic leaders and staff to implement workflows and tools that address these health-related social needs? So to start us off, Monica, give us a little bit of your experience. I know that this is not an area without its own challenges. Can you describe some of the challenges you're seeing when it comes to how to effectively engage clinic leaders?
Yeah, absolutely, Rishi. And I think for us, when we're thinking about how do we move and help the audience understand what they need to accomplish when rolling out an upstream intervention, first things first is talking about the challenges you will undoubtedly face, because we faced all of these, and level set on what are the barriers that people probably already feel, or barriers they should be thinking about as they build their plan. So number 1 is expanding the concept of care, right? I think everyone knows that these social determinants are important. You know, RWJF has done great studies on physicians being bought in to addressing these needs at scale. But what we found on the ground is when we talk about the workflow and we talk about specifically clinical stakeholders treating this as a core component of their job description, there's still a lot of pushback. And I think traditionally, the healthcare system still views social needs as a problem distinct from their own scope of influence. So getting buy-in is really not easy, and that's one foundational pain point. So when we think about clinical engagement, we need to keep reaffirming that there is more to health than healthcare, and it's a core component, as Rishi will talk about later, the culture of the organization. So getting buy-in, number 1, is a big challenge we've seen. The next major challenge we've seen is integration for scale. And there's a lot of things here that I want to discuss as challenges. So we work with a lot of health systems across the country with the best intentions, feel that they have a really strong buy-in around the concept of care expanding to address social determinants, and then start building a workflow. And what ends up happening is a lot of the time, the clinical staff on the ground, sometimes spread out on multiple clinical sites, depending on the scale of the deployment, feel like they weren't included in the development of the workflow, even though they'll be doing the workflow. And that ends up producing a lot of pain and a lot of trust issues and a lot of issues with adoption. So one of the barriers we've always seen, and one of the recommendations we'll talk about later, is how do you get clinical staff involved in the forming of the appropriate workflow and making sure they're incredibly clear on their responsibilities and the tasks they have to complete and the performance metrics they're going to be held accountable to long term. And this becomes more and more important as the size of the deployment increases, because once you have multiple sites, each of those sites are going to have their own structure, their own view on the matter, and making sure they have a seat at the table as early as possible is going to be crucial to not only getting them bought in to help support in the first point, but making sure that the workflow you actually build is going to be best suited to your own organization, because every organization is going to be different. But there's another angle here that we might talk about at the tail end of this conversation, and happy to dig deeper based on questions, is the integration experience from a technical standpoint, where if social determinants already sometimes can be treated as another additive step in someone's workflow, making sure that the workflow from an IT perspective, integration perspective, and the health record as really one of the prime motivations in building a workflow is incredibly important, because the more buttons you add, the more steps you add, the less likely people are going to be engaged. So not only thinking about the day-to-day workflow, but also thinking about the IT integration to make the user experience as great as possible is really, really important to address this barrier head on. And the final challenge we've seen is more long-term. We see a lot of folks tackle the first two in stride. They're able to get buy-in across clinical leadership, across a variety of sites. They're able to tackle the workflow challenges and assign responsibilities. And they end up performing really well for the first year, year and a half. And then they reconsider, and the momentum is lost in year 2 and year 3, because it's hard for them to know what movement they've actually made. And we've seen sometimes a focus on metrics and performance is a little too late. So reporting and metrics are a really key challenge that needs to be addressed as soon as possible, as upfront as possible from all the clinical leadership team before really implementing a program full stop, to make sure the program is sustainable long term. So those are the core challenges we see, and we're going to walk through, Rishi and I, on some strategies and tactics and best practices for all of these. Rishi, back to you.
Mana, thanks so much. And I think to be able to kind of recap here, whether it's buy-in or engagement or lack thereof when it comes to actually designing the workflows, or frankly being able to get and then maintain visibility in terms of how these upstream clinic engagement strategies and projects are working, all of those are things that resonate with our experience at HealthBegins, and I'm sure with a lot of folks who are joining us today. And we wanted to provide another kind of insight here, which goes to some of these aspects of buy-in and engagement, and really speak about the fact that when it comes to engaging clinic staff, we have to recognize that for a lot of clinic systems, the triple aim, if not the quadruple aim, when you think about including joy at work, but these are the central focus areas for many healthcare systems and organizations. That's not news to many on this line. From our perspective, we firmly believe, as Mana kind of mentioned really nicely, that in order to achieve the triple, if not the quadruple aim, we have to, by definition, be able to increase our capacity to address health-related social needs, both to assess them and then to address them using tools like Healthify and others that are out there, as well as with robust workflows. We do know that in order to do that work, to be able to address health-related social needs, we have to have robust and really well-defined formal engagement strategies to support the health professionals in the systems, from frontline staff like medical assistants to clinic champions and others, and we'll talk about those roles in a minute. And finally, we know that we can't, from our experience, really formally, fully engage in a robust way, in a meaningful way, health professionals if we're not considering at least the implications of what an upstream project and upstream change in an organization, a healthcare system especially, entails. And those are changes to what we call the 3 Cs. There are changes that we should anticipate and predict to the care models that we have, and changes that will be required in terms of assessing and then building our capacity, both as care teams as well as systems, especially when we think about a shared capacity with community partners. And then lastly, this is perhaps an element that we're not going to spend too much time on today, but we wanted to make sure that we put this on the radar. Far too often, there's a kind of, when we talk about a formal engagement strategy, there's a tendency to kind of shy away from some of the softer but vital topics of culture. And from our perspective, when a clinic system is meaningfully trying to engage in addressing issues like food insecurity, housing, transportation issues, or even intimate partner violence, for example, there is inevitably a shift in the culture. The expectations that clinic staff have of each other, of themselves, their expectations of their roles vis-a-vis their patients, and also the changes in expectations and norms for how a health system is meant to be as a partner with others in the community, including the social service organizations with whom they're partnering using tools like Healthify. In other words, change is inevitable, culture change especially is inevitable, and instead of being something that we see as inevitable, how can we understand that and assess and predict changes to our culture, and then even maybe embrace this as part of what it means to actually move upstream. So again, we'll speak, and we've spoken in other webinars and in future ones about this cultural change, but we wanted to give both from the Healthify perspective and HealthBegins a quick kind of snapshot narrative of what the challenges are. But let's pivot now from describing those challenges and start getting into some of what we found to be helpful. So we're going to do a deep dive on clinic engagement, especially stakeholder engagement. And as we mentioned in the framing at the top of this webinar, this starts with discovery, a discovery that starts with specifically stakeholder analysis. And so the first step of really identifying and creating a formal clinic engagement strategy starts with naming your stakeholders in those clinic systems. And you can see on the left of this table a series of titles that describe different roles in the organization in a clinic system, that it might be adopting tools like Healthify, it might be taking on projects to better assess and address issues like food, housing, and transportation. And then you can see the respective roles defined for each of these. One of the basic questions that we want to pose to everybody here, especially for those who are just starting out or trying to refine their formal clinic engagement strategy, is whether you have a table like this or a document like this defined. Have you listed out the titles of the various different clinic stakeholders in the sites that you're engaging to move upstream? And have you defined their roles, not just generically, but specifically when it comes to the upstream change? So within that, you can follow along and see, how each title and the respective role might be meaningful. We want to call attention to those that are highlighted in light blue here, specifically the roles of clinic champions, those specifically who are advocates to other clinicians. They may or may not be those with formal kind of recognized authority or power in the organization, but what they are certainly is the person who is the early adopter, and who happens to be, because of their own passion and interest in this area, particularly well versed in upstream issues and social determinants of health. Many of you are probably on the line right now and are those clinic champions, and many of you can probably think of those clinical champions. The challenge is actually not just thinking about the clinical champions, but also being able to anticipate and identify the clinical curmudgeons. Now, curmudgeon probably creates an image in each of our minds about, the type of persona, the image that comes up in your mind when you think about a curmudgeon. We'll leave to you, but from our perspective, what it means in this context is that the clinical curmudgeon is the person who happens to have a good degree of some influence in either a care team or in a whole system, and also happens to have misgivings about implementing or even integrating social needs. It's really key to be able to identify curmudgeons if you have them, and be able to think about a formal engagement strategy to address not just the champions, but those as well. And finally, another really vital kind of category are those super users. Super users may not necessarily be clinical champions. They don't even have to be as outspoken as your clinical champion, but they should be people who are adept with new systems. They're the folks that people turn to when a colleague has difficulty, and they can come in all shapes and forms, all degrees and pedigrees. The super users are those who may have been engaged in other clinic transformation projects, like electronic medical records or creating a patient-centered medical home or any other initiative. Or they may be kind of diamonds in the rough, people who are waiting to be engaged as super users, who have not previously been engaged in other major transformations. So these are the three roles that are in particular a focus for us as we think about starting off on a clinic engagement strategy. In other words, mapping out your clinic stakeholders. The reason that's so important is because it's not just an academic exercise. It's really because you want to be able to understand now each of those stakeholders based on a couple of different domains. For many of you, this is probably a really familiar slide. This is the classic Mendellow matrix, otherwise known as a stakeholder analysis map. You can see here on the y-axis, from low to high, starting from the bottom up to the top, measures of influence. How influential are those stakeholders? And you can see on the x-axis on the bottom, going from left to right, increasing levels of interest in this particular issue. In this case, moving upstream or addressing a social determinant. And as you can see here with those dots in blue, the goal for each system when it comes to developing a formal strategy is to be able to take the list of titles and the respective roles, including those of clinical champions, the curmudgeons, and the super users, and plot them on this 2x2. As you can see, what happens is that then we can take each of these quadrants and be able to define the type of stakeholder that person is. So let's start from the bottom left, category A. Category A is defined again by those who might have low interest in this topic and also happen to have low influence in that clinic organization for that care team. Category B, moving to the right, are those folks who are really interested in moving upstream, have a lot of self-expressed desire to kind of participate, but may not necessarily have as much influence with their peers or with leaders in your clinic system. Category C on the top left are those who have high influence, really influential in the organization, whether through formal recognized authority or otherwise, but happen to have low interest in this particular project, moving upstream. And then finally, you can see then how those with high influence and high interest would be classified in category D. It's surprising how I think each of us perhaps has informal kind of senses of how each of our peers and clinic staff and leaders might fit in these boxes, but how, in our experience, how we often skip over this step when it comes to moving upstream. A lot of clinic systems will just take for granted their assessment of where stakeholders are at without going through the process of literally putting these dots on the map and identifying who's who. This is key for a lot of reasons. It's certainly been applicable in other major kind of business changes in any industry, including in healthcare. This is just what we see as a best practice across any kind of change, and it's particularly notable that we should use this for this kind of uncertain territory for a lot of health systems and moving upstream. So to kind of now do a deeper dive and understand what it means to specifically support those champions at clinical sites and understand how to support them depending on the level of interest and influence, that's something that we want to dive into a little deeper now. I'm going to turn it over to Monica to give us a really great representation of Healthify's experience doing this work. Monica, it's all you.
Excellent, thanks, Rishi. And for this topic, as Rishi mentioned, it's so key to understand the stakeholders at play and mapping their interest level out on that chart. And for us, we're going to talk a bit about, one, internally what you can do to make sure teams are supported, and then externally what you can expect from your partners to make sure your teams are supported in their work. So what I have here is a best practice of a mapping exercise. As Rishi mentioned, one component of this is actually mapping out the clinical team and mapping out where they fall in their interest level of an upstream initiative. And we found that once you have that in place, one of the other steps you can do is actually mapping out the entire stakeholder group across all of the clinical delivery sites. So here's an example. We do a lot of work with the Accountable Health Communities model nationally. And this is a really powerful exercise because one, it forces you to fill in the gaps. And what we found with a lot of our partners is when they start building this map of who owns what component of the workflow, what are the performance metrics for each clinical site, what are the performance metrics for each team, who's going to do things like conducting the actual community beneficiary survey, to who's going to initiate the referral, to who's going to follow up, they realize that there's a lot of gaps in their knowledge, which then allows them to fill in those gaps by bringing in the right people at the right time to actually be around the table, as I mentioned at the top of this webinar, to actually provide feedback on the workflow. So by actually doing this exercise of mapping out roles, responsibilities, workflows across the entire scale of the system and deployment that you're hoping to accomplish, allows you to really make that happen, and it allows people to get bought in throughout that entire process. Some best practices are to think about this in terms of levels. You have different tiers of folks who are going to be responsible for different components of the intervention, whether it be level 2 teams, which are the administrative staff, to level 1 teams, which are the core staff that are conducting the screening. But adding some frameworks around the mapping can allow you to just better organize your initiatives writ large. But the other value of doing this exercise is it's a useful piece of collateral. And we found that when people complete this mapping exercise, they can share this widely across their community and across all of their clinical leadership. So at a glance, people can figure out in the grand scheme of things where they fit, which again reinforces their buy-in to the project. So this is a really powerful mapping exercise, and happy to talk more about this during the Q&A. The next example I want to show is some of the collateral you can share to align and communicate responsibility. So we found that the best way to support someone in this work is to make sure it is crystal clear to them what they're responsible for, what they're going to be held accountable to, and why it's great for their mission. And we found the best way to actually communicate that is building some well-crafted collateral around what are the performance metrics, what are the components of the clinical initiative, and communicating that frequently and widely to anyone who's involved in the process. And the powerful thing is, once you conduct the stakeholder analysis that Rishi mentioned, once you conduct the mapping exercise I mentioned earlier, you have some very clear visibility into what you're trying to accomplish and what metrics are going to be most useful to different parts of the organization. And you can rapidly build pieces of collateral that get people excited about the work. And as I think Rishi called out earlier, bring joy back to the work itself. As Rishi mentioned, doing this work should be a really strong signal culturally for the entire organization, and making a little bit of an event out of rolling out this initiative can go a long way to getting folks aligned and really invested in the success of the work. And if we go to the next section here, so those are two best practices for what one can do internally in the organization. But a lot of the times, obviously from the Healthify perspective, we're working with a lot of partners and trying to help them. And the expectation is most likely that everyone on this call will be speaking with and working with other folks as well. And one thing I want to make sure everyone in the audience understands is how you should hold your external partners accountable to make sure they're fully in lockstep with you and making sure that they're fully supporting the teams you have. So defining external roles is just as important as defining internal roles. So I'm going to walk through some of the engagement models that we use here at Healthify of what are the key components of a go live. So obviously you have the project design. That's when you're establishing the metrics and establishing what the goals are for the entire upstream intervention. Then you have the implementation period. This is when we're conducting stakeholder analysis. This is when we're actually mapping out stakeholders and their responsibilities and implementing. And then we have ongoing partnership success and program optimization. But more specifically, we're going to go item by item. So you can go back to your organization and say, here's what we should expect when we're working with someone to ensure success. So number one, it's really important to have a dedicated external role for implementation manager. This is someone who's going to make sure that they're going to work with your internal project management teams and keep track of any project management templates, any Gantt charts, and making sure that any issues that arise in different milestones in the project plan are communicated to clinical leadership and all of the other stakeholders we've already mapped, sometimes as a level 2 stakeholder. So they're really your quarterback in the implementation process to make sure that all the workflow we spent a lot of time iterating on is actually implemented as best as possible. And you should hold them accountable to that project plan and the timelines associated in that project plan. So that's one key external role, is the implementation role. The next large external role to define is the account manager role. So all of these social determinant initiatives usually have a broad vision. And the first year or phase one is not always where you ideally want to end up. So you ideally want someone who you're working with from the external side, who's really the face and strategic business owner for where you want your upstream innovation and work to go. So the account manager role is really someone who's providing strategic guidance, sharing best practices as the deployment continues after it's already implemented, and can provide more iterative feedback on the workflow as we see issues arise, if some gaps pop up that we didn't anticipate when we're building out the early implementation. And they're really the key person that the executive team should be interacting with. So you should absolutely have a dedicated account team that's keeping track of the executive level goals and making sure that the voice of feedback is actually filtered into the strategic guidance to make the program improve. And the final key role to define externally is the program optimization, or what we call here the product support role. So we go to the next slide. The product support role is really the key external role that makes sure that the workflow you established from the implementation actually continues to stay in uniformity once the implementation is complete. So these folks are making sure that the end users are set up for success after the implementation and during the implementation. They're running things like retraining, providing supplemental training materials, additional onboarding for users, making sure that any bugs in the workflow of the product are dealt with, and really serve as an escalation point for the user base. And this is really important as a specific role when we think about scale, because if you're scaling across multiple sites, things are going to break. And you need to have someone that is an easy person to route to, so you don't bear the burden internally in your organization. When you're focusing on getting buy-in, you can actually move that on, that responsibility, to an external organization and make sure that responsibility is well defined to optimize long-term. So those are the key three roles we think making a successful external relationship: the implementation role, the account management role, and the product support role. Rishi, back to you.
Bonnie, thanks so much. And I think that especially in defining the expectations that health systems can have and clinic champions especially can have for their external vendors, that was a really wonderful kind of walkthrough. And it's important that as we acknowledge the starting point that a lot of organizations who are joining us today are at, many have said that they don't yet have a formal engagement strategy. Some are developing one, and some are a little bit further along. That as we really understand how to define and leverage external support in the way that Monica really outlined really nicely, It's also important to understand what is the next step at a high level in terms of being able to now take that analysis, that understanding of what a stakeholder engagement strategy can look like in the discover phase, and now start to plan. So codifying this plan, again, leveraging your own internal resources as well as those of perhaps an external vendor, is really key. We recognize that when it comes to the plan, it's important to recognize the communication methods that are used to engage different stakeholders. And again, you can leverage your internal resources and the external ones that Monica mentioned as well. But thinking about as part of your plan, the communication approach is really key here. And so we're going to show you a quick depiction of different levels of communication, different methods, and try to bring this to life, everything from the top of the pyramid of what a communication method of true partnership looks like, all the way down to what are called pull communications, and kind of bring that to life in the following way. If you think back to that 2x2 grid that we talked about a little while ago, and again, thinking about different levels of interest and different levels of influence of the stakeholders, we can start to actually identify how to support each of those different types of stakeholders with different types of communication methods, with the goal of actually making sure that we're communicating regularly and openly in a way that's appropriate for each stakeholder. So let's take those who are in category D, if you recall. Those are those with high interest and high influence. The goal here is to actually manage those folks really closely, to the point where they not only part of the project team partnering with you with varying limits of responsibility and accountability, they might even be actually helping to run the project with you. So that means having regular team meetings, of course, and inviting those key stakeholders, those clinical champions, of course, to participate at the very least in an active way in those regular team meetings. Once monthly is a good starting point. And if not participate, even help to run them. So this is a really great way to make sure that you're creating, again, a communication method to engage those clinical champions. The last thing you want to do is to identify a clinical champion and not give him or her the opportunity to actually engage in helping to run the project. Buy-in without ownership for clinical champions can really be a great recipe for burning them out and losing their ability to be a great resource for the upstream strategy here. So managing closely through partnership and models of participation is key. For those who have high influence but are not really interested for various reasons in this particular strategy of moving upstream, of addressing social determinants, it's still really key to be mindful of how to engage them, how to keep them satisfied. And so this requires a slightly different set of communication methods. You want to be able to involve them, provide them channels to consult and advise on the project, but make sure that they're not responsible for key dependencies or key kind of work streams in the project. And make sure that they're also, to the extent that sometimes the lack of interest may yield to kind of negative influence in the organization, you want to make sure that they're not really influencing anything too far outside of their roles as consultants or advisors to your project. And so the method to support this is to be able to provide them a vehicle to participate and consult through regular advisory meetings, regular consultation meetings, making sure there's a regular kind of process. And this means calendaring this, for example, every 2 months or every 6 weeks, making sure there's a calendar invite that's sent out to those stakeholders can be a really good, simple way to start with keeping them satisfied. There are those then who need to be kept informed. These are for the folks who are really interested in this kind of area, have a great degree of personal connection or professional connection to the issue of social determinants of health, especially the role of addressing it in healthcare. They may not necessarily have a high influence when it comes to the success of the strategy, but they still have a role to play. And they're a vital role, actually, because they need to be kept informed. This is a very, oftentimes, clinic engagement strategies when it comes to moving upstream sometimes forget about this role in particular, and that's to the detriment of especially not just the project and the implementation and the outcomes you're looking for, but to the culture change that we talked about earlier. Without keeping a key number of people informed, those who have high interest in this topic, you squander, again, their ability to be up to date, understand the data, and of course, it influences the culture, shift the norms and expectations that you have for each other. So the way to do this for this category of those, again, with high interest and low influence is to, for example, use dedicated emails, webinars, and specific reports that allow folks to be able to stay updated. One of the things we've seen to be a particularly successful communication method when it comes to clinic engagement is to actually then take your project team and then show up at huddles, whether it's the daily huddles that some of your clinic teams might have or weekly meetings. Being able to show up and keep these stakeholders informed is a really great way to make sure that they're proactively engaged. And then finally, what do you do for those who are just not as interested and don't have too much influence in the organization? Obviously, we recognize that there a chunk of the stakeholders in all clinic systems. And the realistic approach is that we don't want to disregard them. We want to just make sure that we're monitoring them and being able to keep them engaged in a way that's appropriate for their level of interest and influence. So the way to do this is to be able to, for example, think about newsletters, web pages, other ways to be able to provide them with the opportunity, if they choose, to engage with information. Those are the pull communications. So this is a high-level approach to thinking about how to create a communication method for stakeholder engagement. It's a way to kind of build out for each of your organizations what a stakeholder engagement plan can be in that second phase. And again, a really welcome opportunity to start asking your external vendors, if you're engaging them, to ask them how they can support you in developing each one of these components. So a lot of information here with a nice pyramid and all sorts of communication methods. Let's recap some of the best practices for engagement that we've covered in this particular section of the webinar. We want to make sure that you're identifying, engaging, and supporting clinical champions and the super users. Healthify, Monica specifically went through really great ways in which your vendors might be able to do that and support you in that process. We encourage you not to forget to involve their curmudgeons. When we think about clinical champions and super users, just don't forget about those curmudgeons as well. They're really important to keep engaged. It's important to regularly share progress and data. We'll go into that a bit more detail today. And then, of course, engage and leverage your vendor and customer success teams from external partners. So that's a recap of what we talked about in this section here. Let's pivot now to the last topic for today and really talk about the best ways to use and share data to really prepare and motivate clinical sites to stay engaged and to achieve their success. And with that, Monica, I'm going to turn it back over to you to give us some examples of your experience with Healthify in doing this work.
Perfect. Thanks, Rishi. And, one of the first steps in thinking about the metrics is understanding who needs to see these reports. And going through the exercises, Rishi and I have already mentioned the stakeholder engagement plan, the matrix, building the mapping of stakeholders is going to help you understand who needs to see it, what metrics, at what time, what's the cadence of scheduling these reports. What I want to spend time is talking specifically around the metrics we found to be really helpful in the early stages of rolling out a clinical engagement model and rolling out upstream innovation. So number one is core raw engagement metrics. So on the left here, we see just some high-level metrics on the engagement rate, the activation rate, and different types of super users. And what we're looking at here is a couple of things. The activation rate is looking at who has actually adopted the workflow that you've set out. So it's kind of very binary. I've adopted it or I've never adopted it. The engagement rate is out of the people who adopted the workflow, how many of them are continuously engaged in conducting that workflow for a certain period of time. We tend to use 30 days, but that's going to be really dependent upon how you define the different stakeholders and what they're accountable to in the specific workflow, whether it be components of screening or components of referral management. The engagement rate is going to be a really important time-bound metric to understand. And these two are really good signals to know how, one, the implementation is going in the early days, and two, multiple months in or a year in or longer, understanding how much has stuck to see if, one, do you need to re-engage, do you need to reinvest in a clinical engagement model or reinvest in onboarding or training or all of the strategies you laid out earlier, or not, or leading to number two, if folks are performing incredibly well and they're super users. And we always like to capture this up front, because when we think about clinical champions, as we map out our stakeholders across the organization and we think about buy-in, we found super users and champions of pursuing a workflow to be incredibly, incredibly valuable. One, it allows them to share the great work they're doing across the team. Two, it gives someone to look up to say, oh, wow, look at this great work this other individual is doing and really living into our culture of trying to move more upstream. So making sure you have the infrastructure to capture the type of information downstream from an engagement metric point of view is really helpful to actually get more buy-in long term. The next bucket of metrics we like to capture is workflow success. And workflow success is really, really helpful when we talk about that definition of the clinical curmudgeon, as Rishi mentioned, because they're looking for success. They're looking for what actually is working when we roll things out. And over here, we look at really tactical definitions around the social need intervention that's taking place, whether it be what needs are identified, what the scope of those needs identification looks like, all the way down to referral completion in the network. So if you identify a food need and you have a workflow to actually drive towards a food intervention, what interventions are actually being successful and which partners in that intervention are being successful. And then looking at time saved, which is a great metric, again, to get buy-in and reaffirm that this is a workflow that not only is supporting the identification of needs and supporting needs being addressed to really help and support the quadruple aim, but it's actually saving a lot of time in our workflow as well, which is a really powerful metric in the early stage to capture when the long-term metrics around medical cost reduction or utilization are take a longer time frame. So workflow success is really, really big, and again, goes back to getting more buy-in from the clinical curmudgeons to see, yes, this is working, and we're actually capturing it from day one. The final bucket, which I think is helpful, is qualitative feedback. And the main thing we do here is NPS scores. So folks know what a net promoter score is. It's a commonly used scoring system, actually used in the consumer world, and a lot of health systems and payers are adopting this too. We adopt it specifically for rolling out a workflow related to social needs and the integrations of social determinants of health. And we recommend doing the same. We get a lot of really powerful feedback from the net promoter score question, which is, would you recommend this to a friend or colleague? And the only things that are positive in the NPS score are if someone rates on a 1 to 10 scale, 8, 9, or 10. So the bar is very high to get a positive NPS score. And as a reference point, the average NPS score in the health industry is anywhere from a -4 to a 5. And it gives you a really good understanding of in the totality of the entire experience, from the engagement to the workflow to the rollout to the implementation. At the end of the day, what is the satisfaction of folks? This is a great way to actually capture that, to know you're on the right track. So these are just a few metrics that we found to be incredibly valuable when rolling out and scaling in the early days. Rishi, back to you.
Monica, thanks so much. And so one quick housekeeping reminder for everybody on the line right now. We're just coming into the home stretch for our presentation. So if you do have questions, comments, Rotten Tomatoes, anything you got, go ahead and share them in the questions section. And in a few moments, Grace will walk us through your questions so Monica and I have a chance to respond to them. And so in closing the loop for this particular topic area right now, we wanted to just recap what we're seeing that really complements what I think Healthify and Monica specifically are experiencing and describing right now about how to make sure that we're responding as part of this upstream clinic engagement strategy. We've kind of touched on what it means to discover, in other words, to analyze your stakeholders, what it means to actually start to put together some components of a stakeholder engagement plan, and then different mechanisms to actually engage and provide data to the clinic staff and leaders and the champions, including their curmudgeons as well, to make sure that they're engaged in the process. The question then is, how do you make sure that there is a responsiveness baked into your clinic engagement strategy? One is just to make sure that you're always considering, as part of your change management approach here, that closing the feedback loop is essential. Again, this is a two-way conversation when it comes to clinic staff and leadership. We want to make sure that they're always being able to both see the data and in the way that Monica described. I think is a really wonderful example of that. We also want to make sure that beyond just being able to see the data and closing the feedback loop in that sense, that there's also a really clear and transparent process to review the challenges that are coming up with the project that may be reflected in the data, may also actually not be reflected in statistics, but are coming across in qualitative ways. Without a process to intentionally be able to structure time, meetings, engage in these huddles, go through the different communication methods that we talked about with stakeholder engagement, without those structures in place and without a clear charter and a clear kind of authority granted to everybody in the clinic system to be able to highlight challenges, those challenges will fester, remain unaddressed, and actually degrade your ability to have a successful clinic engagement strategy. So what's your process, if you have one, to be able to make sure that clinic staff and leaders, depending on what type of stakeholders they are, can share their challenges, review them, and that also then allow you to be able to review lessons learned and identify successful strategies to address those challenges. So the feedback loop is not just about data and making sure people see the reports, but it's also making sure that they have a chance to actually describe challenges and be able to figure out solutions to those challenges and report back on them on a regular basis. The final element of what we've seen to be really, I think, notable, and this is, I think, a newer area, especially for those systems, it may be relevant for those systems that are thinking about how to take your current strategy and start to scale it across other clinical sites, is how we measure clinic engagement in and of itself. Most of our outcomes, our measures of success in this kind of work are related to the social determinant of health that we're looking at, or clinical outcomes, for example, or utilization. Another domain, another outcome domain may in fact be clinic engagement itself. And so for large systems and for those that are really thinking about having a far more robust strategy for engagement, it's important to measure engagement, how well you're doing with that. So asking, for instance, clinic staff and leaders, regardless of the type of stakeholder they are, whether they're champions, curmudgeons, or otherwise, asking them about for feedback is important, but then being able to evaluate whether you're getting feedback in the first place and what the quality of that feedback is key as well. It's also important to consider the quality of the relationships. So this is a way to be able to measure some of the inevitable changes that we are asking for in workflows and the way in which people work with each other. So it's important to assess in a periodic basis. This could be every 6 months or more frequently, depending on the level of your change, asking the staff in different teams that are maybe implementing a new screening process and using a new tool like Healthify. How's it going? What are your relationships with each other? Are they better? Are they worse because of this new workflow? What are your relationships across the organization? And what are, most importantly, perhaps, what are your relationships with your patients? How are they changing because of this workflow? We often don't ask that question and allow staff to be able to give us that kind of feedback. Of course, we want to make sure that we're gauging satisfaction as well of the clinic staff and leadership with the project. And finally, as Monica spoke about really well, we want to use questions like the NPS, the Net Promoter Score, to be able to assess satisfaction overall, but also to identify whether we're creating the ambassadors for this kind of upstream change in our organization. For a lot of clinic systems right now, in our experience, there are initial kind of forays right now into topic areas like food and housing and security, maybe transportation. Many systems are screening for many other social needs as well, but a few are starting to embark on creating projects, more robust partnerships to address food, housing, and transportation in particular. More and more, what we're realizing is that what we're trying to do in each of these clinic systems and across this ecosystem is to build more and more ambassadors, such that if you have clinic staff and champions engaged in a food insecurity project, that they, by virtue of engaging in this project, can learn how to not only address food insecurity better for your patients, but more importantly, be able to get engaged when it's appropriate to then build out partnerships for other social determinants like housing, transportation, intimate partner violence, immigration issues, and so on. As upstream capacity grows in the system, it's important to recognize your ambassadors, and a really great way to be able to do that is to leverage the Net Promoter Score. How likely are you to recommend this project to peers is a good way to identify how well you're doing with the project, but also to identify, again, those would-be ambassadors, not just for this project, but for others. So we've covered a lot of ground, and obviously you can see that even my security software is getting overwhelmed with the topics that we've covered here today. But with that, I wanted to turn this back over to Grace. Thank Monica, of course, for this conversation. And let's see now what types of questions, Grace, we're getting from the audience. Thanks to all of you, and Grace, take it away.
Thanks, Monica and Rishi. That was really a tremendous amount of very deep and useful information. I learned many things myself, so thank you. Now, those of you who are on the line with us, this is your time. We really want to take the questions that you have. So please, any question that comes to mind, no question is a bad question, go ahead and post it in that questions pane on the right-hand side of your screen. Rishi, why don't we start with you? You had mentioned earlier in the hour the importance of culture and culture change. Are there any strategies you can recommend that make that culture change deliberate, not just accidental, not just passive? What have you seen work in the field?
Yeah, in our experience, it starts with actually a really specific focus on doing an assessment, a cultural assessment. That often starts with, of course, the stakeholders who have brought HealthBegins in to be able to partner and move, help cooperate and co-develop a kind of an upstream strategy for the organization. So we often assess, what are the motivations for the stakeholders, the leaders that are bringing us in. Then we actually invite them to start to give us a better perspective on the culture of the organization. That includes not just identifying stakeholders in the way that we've talked about today, but then being able to assess their culture when it comes to the readiness of the culture to be able to move upstream. One of the tools that we use to actually assess culture as well as other domains of readiness is what we call an upstream capability assessment. And we use that kind of 15-minute online tool that's tailored for each system that we work with to be able to give that assessment, both perform the assessment and get the results in a pretty rapid fashion, so that not only individual leaders that are engaging HealthBegins, but that other teams of stakeholders that they want to engage all have a chance to be able to reflect on the assessment, debate any differences of opinion that they might have in terms of their perspectives on their culture in the organization, and then start to actually get into a conversation about how to reconcile differences and anticipate that there's going to be changes in the culture in the organization. So it starts with an assessment. It starts with a couple of tools that I mentioned to be able to support that cultural assessment. And then it actually requires us to continue to kind of surface this issue at every stage, whether it's using the framework that we're introducing here, or the framework, for instance, that Monica and Healthify uses, or any of the vendors that are out there. Whatever framework you use, it's important to, I think, pause from our experience at each stage to be able to assess how this is going in terms of aligning with your cultural, the culture of the organization. And sometimes that means actually assessing whether some externalities, something that's changing in the environment right now, how that's transpiring, how it's impacting the success or the chances of success for your upstream strategy. Changes in, for instance, Medicaid policy in a particular state might have important ramifications for the organizational kind of buy-in to this upstream strategy. We want to make sure that there's a process to check in on culture, and including ways to assess for externalities as well as anything that's happening internally. So in other words, we have to be intentional and deliberate about assessing culture and then being able to talk about culture. And again, our goal is to make sure that we're embracing culture change, because from our perspective, this is about health and not just healthcare. And many of our healthcare systems, despite the incredible motivations and mission of people within it, are still stuck in a system that is not fully capable of working with community organizations and public health departments to fully address upstream issues effectively. We want to move everybody towards that holistic kind of seamless picture of integration that takes an assessment and an embracing of culture change.
Great. Let's hop over to Monica for a minute. Monica, you had discussed the importance of really getting people directly participating in designing their own workflows from the beginning. Maybe you could give us an example of some kind of successful ways you've seen that done. And just to piggyback on that, there's one more nitty-gritty question from Matt, who's on the line, that you could probably help us with real quickly. And he would like to know, what is the ideal size team to fully utilize Healthify to its full potential? Perhaps that question also applies to, you know, the navigating the size of teams and doing this work in general.
Yeah. So for the first question, in terms of strategies on, how do you get that work group together to make sure everyone's bought into the workflow, we actually tend to define a user work group during the pre-implementation implementation process. And that serves as two roles. One, it's a dedicated group of folks who are going to eventually adopt the workflow down a few months from launch date or during the launch time. But two, can also serve as really a beta test of the workflow itself. And it's through that early implementation process that a lot of kinks are usually figured out. And that's our way of tackling that, is, going back to the mapping exercise, let's get a group of 5 to 7 care managers. Y'all are going to be the key user group in helping establish the workflow. And more often than not, that same group ends up being super users and evangelists and ambassadors for the program after the fact. So you almost are kind of preempting and incepting that idea to begin with in the organization. So that's the best way we found, is getting those folks around the table and actually running workshops and sessions around specific workflow and getting quite detailed, as in, here is what you're going to see on a page when you're conducting a screening. Here's where you're going to go next. Here's where you need to record the information. Are you comfortable with the way that information is going to be recorded? Do you want it in a free text field? Do you want it in a drop-down? What's too much? What's too little? So we get quite granular with them, and they usually really appreciate that, because they're doing that kind of detailed work day in and day out. In terms of the question from Matt, thank you again for asking. Honestly, it really depends. We've had deployments where we're deployed at a really small community-based organization or a small FQHC to national deployments with payer organizations across the country. And the implementation and the scope always changes. But going back to the culture component that Rishi said earlier, for us, when we think about culture, it comes down to what's the vision and what are the goals that this organization is trying to accomplish in this space. And once you get that right, it's easier to understand how broad or how narrow you want to go. And it's also easier to repeat that mantra so the culture sticks. So what we usually end up doing with a lot of our partners who are unsure how deep they need to go, how many folks need to get involved, we do an analysis with them to say, what do you actually want to accomplish? What's the end goal here? And that usually can be pretty illuminating to understand, do I need to involve my entire care management team? Do I need to have this in a certain set of clinics to initially start? and helps figures out some of those nitty-gritty scope questions from that exercise.
So this question from Stephanie, who's on the line, broadens the scope of this presentation a little bit, but it's probably a question on a lot of people's minds. And that is if you can speak to how these engagement strategies might also apply to nonprofit and community organization engagements. That is a whole big subject in and of itself. In fact, on the HealthBegins site, you'll find some webinars on designing and financing sustainable community health investments that speak to that subject. But we have gone through a lot of engagement strategies today. Those might have some application with community partners as well. Maybe Monica and Rishi, each of you could throw out a few suggestions of how to make that leap.
Yeah, I mean, one component with the community partner relationship, just generally that ends up being more salient, is the concept of trust. A lot of community-based organizations are unsure about what their relationship with the clinical world and the healthcare system is going to look like. So investing, same with the idea of getting buy-in as early and as quickly as possible, the same thing applies to community-based partner relationships. But the thing that really needs to be clearly communicated to the community-based partner is what are the incentives for them? When you're working with an external partner like that, where you're going to be highly dependent upon the service they deliver, you need to be very clear with them around what's in it for them. A lot of community partners come to us and say, hey, the health system wants to work with me, or the payer wants to work with me, and they're not sure what that means for their own sustainability long-term and what it means to their day-to-day work. And sometimes they're scared, and sometimes they're hesitant, and sometimes they have trust issues to overcome that hurdle. So that's probably the only key change I'd make, is that some of the communication needs to be really incentive alignment focused versus a lot of the upfront lifting on mapping stakeholders, which will undoubtedly still be important, but the alignment of incentives is really a key piece with the community-based partners. I don't know, Rishi, if you had anything to add there.
Monica, no, I think that's. I think you touched on it perfectly. Yeah, nothing to add.
Great. And one follow-up there from Matt on the question about team size. These workflows that you have laid out, how flexible can those be for various size organizations? Can they be customized? Can they still be successful?
So I'll take a first stab at that. They can still be successful, but sometimes this is where expectations sometimes don't line up with reality, where someone might expect, hey, I want to roll out a large system-wide way to identify social needs at scale. And we see some of this with the accountable health communities model, where there's a large ask for screening thousands and thousands of people, but then the actual bandwidth needs, a staff perspective, are not there. So that comes to a head, and we have to kind of figure out what's going to happen there. Are there unique, innovative things we can do to help scale up screening? So again, it comes down to what's the goal? Do we want to really identify food insecurity in a diabetic population and then align our staff mix appropriately to that, solving that problem? Or do we take a broader role and align that way? And there's some interesting things you can think about in terms of scaling if the staff is not there. So we've done things like scaling up screening that is directly administered by the individual or the caregiver. So the caregiver completes a screening for social needs on behalf of someone, or someone completes it on their own, all the way down to folks searching for community-based services on their own, to actually getting the community-based partner much more directly involved in care and allowing them to coordinate referrals for the membership and for the consumer in that network. So there are ways to divvy up responsibilities, but the scoping question is still around how broad do we want to go with our addressing of going upstream, or do we want to go more narrow? And our recommendation, generally learning from a lot of pain over the years, is narrow ends up being better. Narrow is where you can prove success more quickly and more effectively to help justify a larger scope. And I think we made the mistake maybe 2 years ago, really wanting to say we want to have a broad way of thinking around social needs generally in the interventions and the coordination of these needs. And we ended up boiling the ocean, and it was hard to get alignment and communicate effectively. So one small recommendation is to really think about this as an iterative game, that proving success in a small scope allows you to prove success in a larger scope as you go forward.
Thanks, Monica. We're nearing the end of our time, but I want to leave everybody with this really lovely perspective that came in from Julie Hudman, who's on the line with us. Julie says, she writes here a message that I think everyone should hear. She says, I love this and implemented some pieces of this while CEO at a health center in LA. But I think the biggest challenge for FQHCs is that there are too many competing projects and requirements, with many of them tied to payment. Trying to manage all of these requirements and implement a new workflow in this environment with challenging patients and limited resources seems next to impossible. But I do think it is what we need to be doing. Keep up the good work. Keep up the good work, everyone. That starts with your participation here today. Thanks again for being with us and for your questions. As we mentioned before, we will be sending you a recording of this webinar if you want to refer back to it. We are also going to send out an email with a unique link for you to reply with your answers to our survey about how this webinar went and what we can give you on the next occasion of our next webinar. That'll pop up on your screen as soon as you sign out. And we will see you again for our next webinar. Thanks again for being with us.